Hi, everyone. I am Jon McClellan. I go by Jack. And we're going to talk about bipolar disorder. I've given this talk for this group before a few years ago. I'm a professor at the University of Washington. As far as my disclosures, I have grants from the NIH. I studied genetics, mostly of schizophrenia, some of bipolar disorder, more classic adult manic depressive illness bipolar disorder. I'm also the medical director for Child Study and Treatment Center, which is the Kid State Hospital in the state of Washington. And I guess the other disclosure is, as you're hearing this, the bipolar disorder has been a fairly controversial issue in kids. I helped author the practice parameters for the American Academy of Child and Adolescent Psychiatry. And there was a lot of controversy around the writing of that. And this is now an older document. They've not been redone since 2007. But so as I'm talking, I'm clearly on the side that manic depressive illness is a real illness. It's mostly an adult or later adolescent onset illness. And that whatever we had been diagnosing bipolar disorder in kids was probably something else. So just to be clear about that, other people would disagree with me. But I think that controversy or the issues in definition then really challenge how we talk about what appropriate treatment guidelines are, because it depends on what bipolar disorder you're talking about, frankly. That historically, and really kind of we've gone back to this in the current DSM-5 definition, bipolar disorder, manic depressive illness, it's this really remarkable psychiatric syndrome where people have these distinct, clear episodes of mania and depression that are much different than their baseline functioning. And in those episodes, there's these marked, persistent changes in their mood, thought, sleep, and energy. And you don't miss it. If someone's having a manic episode in front of you, you are aware that something is wrong. That illness, which has been described for millennia, has peak ages of onset between ages of 15 and 30 years, with the peak age of onset around age 20. And it's really rare to see that illness below the age of 14 years, that is not a childhood illness. It's highly heritable. There's probably genes waiting there to be found. But it's also become a bit of a muddle because the definition of bipolar disorder has become much broader, especially over the last 2 decades. So, and the real controversy and the question that came up in kids and what has become to be defined as pediatric bipolar disorder is, does chronic irritability, mood lability, and severe emotional outbursts that start in early childhood, is that bipolar disorder? And it really depends on how you define bipolar disorder. That some of this is just simply an issue of definitions, and it's so a challenge in our field that the only way we define disorders is based on agreed upon criteria. Since we don't have blood tests or biomarkers, there's always going to be definitional issues or debates about which criteria define a disorder and how you define those criteria or interpret those criteria when you're with an individual patient. So again, with definitions, bipolar 1 disorder, you need to have at least one full episode of mania in your life. Bipolar 2 disorder, which I think is a little sometimes harder to diagnose just because it's the boundaries a little blurrier. Folks with bipolar 2 disorder have one or more episodes of major depression, and then some periods of hypomania. And to be fair to DSM, hypomania still requires a 4-day duration of manic symptoms. And that again falls into, so hypomania is not just simply being hyper excited for the afternoon. You're supposed to have it for 4 days, but not more than 7 days. Otherwise it becomes a full manic episode and you have bipolar 1 disorder. Cyclothymia means you have a lot of hypomanic and dysthymic episodes that persist for at least a year in adolescents, 2 years in adults. A mixed episode is having symptoms of both mania and major depressive disorder kind of at the same time, with a duration at least of a week. And this is a key definition because it's not the way the pediatric definitions have often been applied. Rapid cycling by DSM means that you have 4 full episodes of a mood disturbance, so they last at least a week or 2 weeks, depending on whether it's mania or major depression, over a 12-month period. So they still have full-blown episodes. They just have several of them in a year. Um, at this point, as far as the epidemiology, and again, there's debates in this depending on how you define the disorder, but overall, the lifetime prevalence of bipolar disorder, using more classic definitions, it occurs in around 1% of the population, with a slight 0.06% being bipolar 1 and the rest being bipolar 2. There's approximately an equal gender ratio. And as I mentioned, that most people with the onset of the classic disorder, it happens in their late teens, early 20s. There does seem to be some individuals that have a later peak, sort of in middle age period, 45 to 54 years. But depending on how you define it, these numbers can change significantly. From a genetic standpoint, in some families, this seems to run like a dominant mutation. And that in general, if you have a first-degree relative with bipolar disorder, with classic manic depressive illness, you have about a 10% risk of getting the illness. It remains highly heterogeneous genetically, and we're still working on identifying specific mechanisms. There's also environmental stressors can clearly contribute. It's often the case that people have some sort of environmental trigger or stressor associated with it around the time of their first episode. There's then also these other issues that people with childhood maltreatment are more likely to get a diagnosis of bipolar disorder, or people with substance abuse. But I think that again falls into, is that classic bipolar disorder, or is it mood debility and instability that you also see with people with trauma histories and substance abuse problems? So the controversy, and some of this we've actually moved beyond, because DSM-5, frankly, told child psychiatrists to stop diagnosing everyone with bipolar disorder. That was kind of the take-home message, and that you should be using DMDD. But for a while, this was a huge, huge topic. At our state hospital, it went from having no kids, younger kids, ever referred to the diagnosis of bipolar disorder, to all of them being referred with a diagnosis of bipolar disorder. And they were the same kids, it's just a different label. So, and these are the definitions, again, that are in the child literature that don't necessarily reflect what is certainly in DSM-5. And pediatric bipolar disorder has been variably defined as chronic non-cyclical irritability. That's the Wozniak paper that came out that really sort of triggered a lot of this, of changing the definition. And that's at Mass General. And so you compare that with the rapid cycling group. This is Barbara Geller at WashU, where they defined rapid cycling different than having 4 full episodes a year. You either had ultra rapid cycling, where you had very freak manic episodes lasting hours to days, but all of which were less than 4 days in duration. So none of them met criteria for hypomania, much less mania. Or you had what was called ultradian cycling, where you had repeated brief minutes to hours cycle that occur every day. And to some degree, these are described in the same phenomenon. Depends on whether you're a lumper or splitter. The kid gets irritable every day, so that's chronic non-cyclical irritability, or the kid has episodes every day where they're irritable, but they don't last all day. They last minutes to hours. That is ultradian rapid cycle. There's also this concept that's sort of worked in with this, recognizing the kids, because they don't often meet criteria for classic manic depressive illness, they have bipolar NOS, which again is a pre-DSM-5 term, but they would have subthreshold symptoms. So they would elevated or irritable mood more than 4 hours a day and at least 4 days in their lifetime, which again is an interesting definition if you think about it. Most of us have probably had some days where we had elevated or irritable mood for a few hours. Anyone who's ever taken a kid to a Disneyland has had kids that have had elevated mood for 4 hours in the day. But all this means that there's just widely variable patterns of illness, with episodes lasting minutes to hours to 1 or 2 days. Towards that's just simply their baseline functioning. They're always bipolar. So if you look at the pediatric bipolar literature, regardless of what you think about the diagnosis, the earlier onset is associated with a longer duration of untreated illness, greater severity of depression, and greater comorbidity. And beyond substance abuse and anxiety, there's a huge overlap between the pediatric bipolar literature and kids that have ADHD and disruptive behavior disorders. They didn't find any differences in reported rates of psychosis or mixed episodes, at least in the study. And again, they're looking at 15 studies across more than 7,000 kids. And in that, and again, you probably have got a range of diagnostic criteria that enroll people in the studies, because the average age of onset in these studies range from 9, which is more of a classic pediatric bipolar literature, to someone who's average onset of 37. So there's a lot of mixing of different kinds of clinical presentations in these studies. So in pediatric bipolar disorder, most of the presentations in the literature are considered atypical or spectrum based on the classic adult definitions. You've got a lot of mood and behavioral instability, agitation, irritability, explosive outbursts. We already talked about chronic aggression, so a lot of these kids fell into that category. One of the interesting things was you could be bipolar disorder or you could have mania in different settings. So you were manic at school, but not at home, or vice versa. Again, a very high rate of disruptive behavior disorders and ADHD. But some of the studies diagnosed toddlers with mania, including, and did antipsychotic trials on toddlers with mania. It is clear that, however, they're defining this also, these patterns run in families. It doesn't necessarily mean that that's the same disorder. I mean, that's the same disorder as classic manic depressive illness, because in families that have kids that have these difficulties, they often have parents that have ADHD, substance abuse problems, impulse control disorders. The other sort of interesting, and it is a dilemma, when does your illness actually start? Because to be fair, if even in classic manic depressive illness, you don't know the person has manic depressive illness until they have their first episode of mania. But it's pretty common that people that by the time they develop their full-blown manic episode, they've had preceding periods of depression, significant depression. And so in reality, they probably did have the start of their illness with those depressive episodes, but there's no way you could know that until they eventually had their manic episode. It's also true that adults with bipolar disorder describe difficulties in childhood with anxiety, depression, behavioral problems. And so on one hand, if you look backwards, you think, well, those may be symptoms, the first symptoms of the illness. The problem is you can't look at those symptoms right in front of you, the kid, and predict whether or not that kid is going to go on to develop classic manic depressive illness. We need markers to be able to do that, but we don't have markers like that at this time. So the other way to think about this, which is data that I think makes more sense to me, is that you look at offspring of adults that really do have classic adult manic depressive illness. So what do those kids look like? And in theory, if especially with some of the effects that increase over each generation, anticipation and genetics, that you might actually see in families that have classic manic depressive illness. In theory, you could see people getting it younger and younger in childhood. However, when people looked, that's not what they found. What they found is that offspring of people with classic manic depressive illness, they are at higher risk to develop classic manic depressive illness. And really with very rare onset below, adolescents, younger than adolescents. So in the Amish cohort, which is a classic cohort, that there was no cases of prepubertal onset. Duffy did this Canadian high-risk offspring cohort. In that study, the average age of onset of bipolar disorder in the offspring was age 20 years, which just is consistent with the epidemiologic data. There's also a study done in the Netherlands, the Dutch bipolar offspring study, and again, average age of onset of 20 years. The other thing clinically, that the at-risk kids do not look like what's been described as pediatric bipolar disorder. They're not presenting with explosive, irritable outbursts. If anything, they have difficulties with internalizing behavior, sleep problems, sometimes cyclical patterns in their moods and sleep that have not yet fully evolved into bipolar disorder. But they're not sort of the angry, irritable, explosive kids that the bipolar literature in kids describes. And it's also important to note that even in high-risk studies, most at-risk youths do not go on to develop bipolar 1 disorder. But certainly some do, and more than the general population does, but most people do not. So how did all this evolve? And folks who've heard me speak before have seen these slides before. Partly this is, again, just how we use diagnostic criteria, and frankly, structured interviews were sort of a problem in this. So when people started diagnosing pediatric bipolar disorder, all they were simply doing was sort of blindly going through DSM-3R criteria. And DSM-3R criteria for mania got rid of the duration criteria and really allowed irritability to be a major factor with mania. So not surprisingly, if you go into an ADHD clinic and you ask moms of their kids, did the kid have distinct periods where they're irritable and they have increased energy and rapid speech and reckless behaviors? The mom goes, yes, that's why I brought them to your ADHD clinic. And it turns out like 25% of the kids in those clinics were meeting criteria for bipolar disorder if you apply them non-specifically. And then you get in the debate, what is non-specific? Because if they meet the criteria, some people say, well, those are the disorders. If you meet the criteria, you have the disorder. It doesn't matter if it looks completely different clinically than what the classic illness looks like. The other overlap, of course, is that given the effects of trauma and PTSD on kids, that those individuals often have mood instability, they're hypervigilant, behavior discontrol, they have a lot of problems with sleep, they often have dissociative symptoms, which may get reported as psychotic-like symptoms. And those criteria can all be taken in, collectively and said, well, that's also bipolar disorder. And so this is what happened. So there's a lot of kids with mood instability and sleep difficulties and reckless behaviors in psychiatric clinics, and that historically, and they don't look clinically like classic manic depressive illness, but they're also difficult to treat kids. They did not fit neatly in any distinct category, and all of a sudden the bipolar label just seemed to fit for a number of those kids and gave clinicians something to diagnose with. And so with that change, with these papers, all of a sudden, rather than being a disorder that in the entire general population occurred in 1% of individuals, there were estimates that 1% of kids were affected. And given the way the pattern of illness goes, if that were true, then you should have a huge number of adults with it, because it keeps increasing in prevalence as people get older. And there was obviously, the rate skyrocketed in the United States. And in doing so, it really changed the way that these kids' problems were conceptualized, because if you have bipolar disorder, probably more than any other disorder, maybe except schizophrenia, it means you need intense medication therapies based on the adult literature. And there was no doubt that with this diagnosis, there was a great increase in the increased use of psychotropic agents in kids. And whether it's coincident or not, the change in how bipolar disorder was diagnosed in kids came around the time that the second generation antipsychotics were introduced into the marketplace. And so these are national trends of bipolar disorder that, again, started in 1994, 95, which is when the Wozniak paper came out, in both youth and adults. And you can see there was some rise in adults also. That some of this has also been an issue in adults, the broadening of the diagnostic criteria. And, do adults with trauma-related syndromes or borderline personality disorder or substance abuse, mood instability, do they all have bipolar disorder too? And in that regard, the rates of bipolar disorder can increase to 5 or 6% of adults. Anyway, you can see that in the United States, the rate of the diagnosis of bipolar disorder skyrocketed in office-based visits. And probably not coincidentally, this is the rate increase of kids on antipsychotic medications in the United States over the exact same time period. So the two are directly correlated. Unfortunately, as part of this controversy, there were some bad things that were happened. I was on 60 Minutes discussing this case, and it's a little bit older now. We don't need to go into it, but unfortunately, as younger and younger kids were diagnosed with bipolar disorder, that those kids were placed on really significant medication regimens. And in this particular story, the young lady was 4 years old, And she and her two siblings and one of her parents were all diagnosed with bipolar disorder, and they were all treated with quetiapine, valproate, and clonidine. And unfortunately, this young lady, she didn't like going to bed at night, so they kept giving her the clonidine to help her sleep, and she didn't wake up one morning. And it was a tragedy. Given all these concerns, and really the loss of any specificity for the diagnosis, DSM-5 created disruptive mood dysregulation disorder with the goal of capturing kids that have chronic irritability and anger outbursts. And in rewriting or at least refining the bipolar disorder criteria, they just more strongly emphasize that the classic definition where the mood episodes are quite distinct, and marked changes from a baseline functioning, and all the symptoms that are clustered together. It's not just this mishmash of symptoms, but you have these marked changes in sleep, energy, thinking. And obviously DMDD, temper outburst and persistently irritable mood that's present in two or more settings. I will say, and this was more of an issue for the aggression talk, there are lots of kids that have temper outbursts that don't have them 3 times a week, or they're not necessarily irritable in between. So this doesn't solve the entire problem of how to conceptualize or categorize kids that have anger problems, but at least it gave a different category to put all the kids in other than bipolar disorder, without necessarily any presumption that we know what it is or how to treat it. Of course, you're starting with a brand new disorder, so how to treat it remains a matter of research that needs to happen. And this has influenced people's diagnostic practices. Bob Finling published a study this year where you can see that the rise in the diagnosis of bipolar disorder peaked and started to come back down again, and that the diagnosis of DMDD started going up. And at least in our clinical settings, we've seen this as well too. Now all the little kids come with a diagnosis of DMDD. You can argue whether or not it matters or not, since many of those kids are still treated with antipsychotic medications. And to be fair, we need better interventions for that still, but it probably is a more honest description than trying to imply it has the same, it's the same illness as classic manic depressive illness. So what is bipolar disorder? Again, there's the classic illness, there's severe mood dysregulation, there's pediatric bipolar disorder, which is mostly kids with ADHD and disruptive behavior disorders that are angry, irritable, and explosive. And in community settings, there's all sorts of individuals who are moody and impulsive and raging, and that and they get diagnosed with a lot of stuff. Unfortunately, kids still don't fit neatly into categories, and the diagnoses don't tell us enough about how to treat or what to do about it. And that's where we need to get better. There's also this interesting problem that what diagnosis you get if you're a kid often has as much to do with which clinician you see as what your symptoms are. And depending on which office you walk through, you either have bipolar disorder, DMDD, PTSD, or something else. So all of this makes defining specific treatment algorithms a little bit challenging because it depends on which syndrome you're talking about. And trying to extrapolate from the literature, most of my focus is going to be on classic manic depressive illness because it really does matter knowing how to treat that. When a person has that, that's a life-threatening illness, and people and effective treatment can basically return someone to normal functioning. Not everyone does, but it certainly has that potential. So, and most of this, it gets extrapolated from the adult literature, but the medication therapies are really specific to different phases of the disorder with acute mania or mixed episodes, maintenance treatment, and the evidence is best for those two. And then the depressive phases, and those frankly remain hard to treat, and we need better options for those. There's clearly psychosocial therapies that need to be added into addressing both the person's mood states, their functioning. Preventing relapse is a huge issue, since most people with classic manic depressive illness have 5 or more episodes before they finally take their medicines. And then unfortunately, there's also lots of comorbid difficulties, and especially in the adult world, substance abuse. So in the adult literature, acute mania The best evidence is for antipsychotics, lithium, and then some of the mood stabilizers or anti-epileptic drugs, valproate and carbamazepine. There's limited evidence for treating bipolar depression with the olanzapine fluoxetine combination drug, some evidence for lorazepam and quetiapine, and for lamotrigine. And in regards to maintenance treatment, lithium, and again, the antipsychotics and valproate, there's some evidence supporting those. This is one area for pediatric bipolar disorder, in part because all of the atypical antipsychotics were able to get, or many of them were able to get an FDA indication for this, that there are a number of drugs to choose from. Now, whether or not the literature actually reflects classic manic depressive illness is a different question, but the drug companies absolutely want to get pediatric indications for this that extended their patent life. And so many of the second generation antipsychotic agents are approved for either mixed episodes or a manic phase. And most of those start at age 10 years. Olanzapine starts at age 13 years as far as the FDA approval. And in kids, lorazepam and then the olanzapine fluoxetine combination drug are both FDA approved for depression, for bipolar depression, starting at age 10 years. Lithium was grandfathered in based on, if you had a 15-year-old 30 years ago that had real manic depressive illness, it would have been completely unethical not to treat them. So the FDA gave approval for it. There's now some studies supporting and warranting that approval as well. So if you look across antipsychotic trials for pediatric bipolar disorder, this is a meta-analysis of 19 clinical trials, 14 RCTs versus placebo. Then most of the trials, like in all of our literature, are short-term. And interestingly, the age range is anywhere from people 5 years of age to 22 years of age. In general, the second generation agents are helpful for mania and mixed episodes with improvements in symptom severity and functioning. But unfortunately, they don't work all that well for depression. And there's, like most of our literature, there's single agent trials. So we need a lot more comparative trials, and we certainly need longer term trials, or longer duration trials. One of the issues comes up: what if you have someone with classic manic depressive illness? I would not use this for kids who are aggressive and explosive, but for people that have real classic manic depressive illness, treatment compliance is often a major issue. So can you use the long-acting agents? You certainly can. They're FDA approved in adults. That risperidone, the microspheres, and their piprazole long-acting agent are both approved for maintenance therapy, and then paliperidone, the monthly version of that long-acting agent, was approved for schizoaffective disorder. They're not been systematically studied in kids. And again, I would only use these to treat well-established classic manic depressive disorder, which is mostly going to be a later adolescent disorder. Lithium remains one of the most effective and kind of the most significant advance in therapeutics and psychiatry, arguably, is lithium in the 1950s, right? There was people who were institutionalized for years who got completely better and were able to go on and go back to whatever the lives were. And so adults, it's certainly a first-line treatment for acute mania. It's also very effective for maintenance treatment. And interestingly, it's one of the few drugs that we have that has documented effectiveness at reducing the risk of suicide. And that's for both bipolar and unipolar depression. By itself, there's limited efficacy as monotherapy for bipolar depression. And then there's all sorts of different sort of studies in adults about different combinations of things. But overall, lithium is helpful for a lot of different aspects of bipolar disorder, with at least similar, if not greater, efficacy compared to some of the other agents that are out there. For pediatric bipolar disorder, there was the CULT study that looked at both acute mania and maintenance treatment and had positive effects for both. Duffy found that lithium was not as helpful as risperidone was for kids with chronic mixed mania or mania that also had ADHD. And again, you may run into some diagnostic issues about which illness we're actually treating here. But the take-home point really for lithium is if they have classic manic depressive illness, lithium remains a drug that they should be tried on at some point. Anticonvulsants are really an interesting literature because this is different than the adult literature. In large randomized controlled trials for pediatric bipolar disorder, these are, I think, all industry-sponsored trials. Valproate was not superior to placebo. Adjunctive lamotrigine for maintenance therapy was not superior to placebo. Oxcarbazepine was not superior to placebo. Topiramate, not superior to placebo. So for whatever it is pediatric bipolar disorder, which is mostly explosive aggression and outbursts, the anticonvulsants don't seem to be very helpful. And again, that literature, then you have to interpret what, in fact, was the diagnoses that were included in there. It certainly was a much broader definition of bipolar disorder and probably included a mixture of perhaps the classic illness plus kids who were more, just chronically irritable and aggressive. But they included kids as young as 3 years of age. So that's clearly different than the adult literature. The adult studies at this time support valproate and carbamazepine for acute mania. And even in the adult literature, gabapentin, lamotrigine, topiramate, and oxcarbazepine are not that supported or not well supported for acute mania. For pediatric depression, bipolar depression, again, the olanzapine fluoxetine combination had some positive therapeutic effects. Unfortunately, again, as if everything with olanzapine, the weight gain problem is a huge issue, which is why we generally hold off using olanzapine as a second-line agent, just because some children gain so much weight on it, it becomes a major problem all to itself. Lorazepam is probably the one that's got the most attention. It got himself an FDA approval for treating bipolar depression in kids. They had a positive 6-week randomized controlled trial. I took some issues, which was published in the Orange Journal, just about the clinical significance of that trial. They clearly separated from placebo statistically, but the differences in the severity and functional ratings were not all that clinically substantial. And there was no differences in rates of remission. So it was helpful, but how helpful, I think it remains a question. And interesting, in kids, different than the adult literature for bipolar depression, there's 2 negative trials of quetiapine. So at this point, if you're treating bipolar disorder in kids, it's lorazepam or the olanzapine fluoxetine combination are the 2 choices that have some evidence support. And obviously in the adult literature, fluoxetine, lorazepam, and quetiapine all have randomized controlled trial support. And in general, across for treating severe treatment-resistant bipolar disorder depression, clozapine and ECT, there's some support for those. Antidepressants are another interesting issue in bipolar disorder because of the concern that in using antidepressants, you're going to increase the risk of cycling someone into mania. And so especially using them as monotherapy, that's generally not recommended by most standard of care guidelines. That they're only recommended if you're going to use them at all to add to someone who's already stabilized on a mood stabilizer regimen. And then the person needs to be closely monitored for the emergence of manic symptoms. They may be more helpful for people that have bipolar 2 or bipolar unspecified, but that becomes a fairly ill-defined group over time. And in general, the data for using antidepressants in people with bipolar disorder, whatever the definitions are, is limited in both kids and in adults. In treating bipolar depression, again, this is just looking at the adult literature. There's really very limited evidence at this point for adjunctive ketamine. Everyone's all excited about ketamine for severe refractory depression, but in the bipolar world, this has not been studied very much. And there are some mixed results, so some positive findings, some negative findings for omega-3 fatty acids. I also was just looking up for other treatments that we're using for treatment of refractory depression. There's really very limited data and without well well-designed randomized controlled trials for transcranial magnetic stimulation treatments. And at this point, this is simply based on the adult literature. There's no studies that are systematic of these issues in kids. It's interesting. It's also important to pay attention. What do people recommend you don't use? And again, these are based on treatment guidelines published for adults. So lamotrigine, gabapentin, and topiramate are not recommended for acute mania. That antidepressant monotherapy is not recommended, nor is risperidone, aripiprazole, or isoprazinone for bipolar depression, just given the lack of data or the negative data. It's also clear that because the data is not only limited, but it also is complicated because studies use different combinations, so then they don't replicate each other. That the guidelines vary then in regards to how standards are made or how recommendations are made. The question comes up, how do you treat bipolar 2 disorder? There's very limited data in adults, and it's really lacking in kids. If someone is really having hypomanic episodes, then use the same treatments that are recommended for full-blown mania. And for bipolar 2 depression, at this point, based on this is guidelines for adults that were developed in Canada, the best evidence is based on quetiapine, or is for quetiapine, and there's some evidence for lithium, lamotrigine, sertraline, bupropion, and venlafaxine. None of this relates to kids. There really isn't great data for kids. What comes up a lot, especially back when pediatric bipolar disorder was all the rage, was what about stimulants? You don't normally think about using stimulant medications in someone that's having a real manic episode. But if you look at pediatric bipolar disorder, which is mostly kids with explosive irritability and ADHD, stimulants completely can be helpful for that. And in fact, should not be avoided in those kids. They probably shouldn't be diagnosed with bipolar, but the focus is on optimizing their ADHD treatment. And again, as I mentioned, if someone develops real full-blown mania, we generally do not recommend using stimulants. And I suppose can think about them once their mood disorders are stable, or the mood episodes are stabilized. But if you develop classic manic depressive illness, that illness takes priority over treating other things. It's also clearly important, even though a lot of the focus is on medications, is to think about psychotherapeutic interventions. There are lots of different strategies that have been developed, mostly based on kind of CBT or psychoeducational interventions. There's child and family focused CBT, there's family focused treatments. There's something called interpersonal and social and rhythm therapy, which is interesting in that it does recognize that bipolar disorder episodes are more likely to be triggered if you have disrupted sleep or just a lot of stress or erraticness in your social functioning. So having people sleep at night, having people don't take jobs where you're on swing shift for 2 weeks and then day shift for 2 weeks, those kind of things probably do matter. And then there's a lot of focus on psychoeducation and relapse prevention. They said in the adult literature, it takes most folks on average 4 or 5 episodes of relapse before they finally agree to take the medicine. And they can often destroy their lives in those 4 or 5 episodes. So it is anything you can do to actually get them to stay compliant with their treatment and to get into maintenance phase treatment and not have relapses, the better off they will be more. And finally, there's more recent stuff about dialectical behavioral therapy. My suspicion is this more reflects to sort of whatever the broader definition of bipolar disorder is, because you're treating mood instability and dysregulation, and all of which is a good thing to use DBT for, but I don't know that DBT actually necessarily helps during the middle of a manic episode. Some of the DBT skills are good for everybody as far as just problem solving and negotiating conflicts, and so in that sense, it makes perfect sense for all people to get it. So in summary, for bipolar disorder, diagnosis matters, and really you have to start with that before you decide on what it is that you're treating. And then classic bipolar disorder most often presents in later adolescence and young adulthood, and that frankly, whatever it was the pediatric bipolar disorder literature from 1995 up to DSM-5 probably does not, for the most part, represent classic bipolar disorder. And what to do with that literature is an ongoing discussion. For bipolar disorder itself, antipsychotics and mood stabilizers, particularly lithium, are indicated for mania, mixed episodes, and maintenance treatment. Bipolar disorder, bipolar depression is difficult to treat, but lorazepam, olanzapine plus fluoxetine, and at least in adults, quetiapine has some support. And that's also really important to think about supportive and psychoeducational treatments to address relapse prevention, mood stability, coping strategies, and family functioning. And I also threw this in there for folks as a reference, but this was just a nice table that outlined what the different FDA approvals are for drugs to treat different phases of bipolar disorder. And I highlighted in red the ones that also have FDA approvals for kids.